Hello everybody and welcome to another tutorial. This one is focused on human factors in acute care. I think this is a very important topic because actually in a specialty like acute medicine, where the environment is always changing, the personnel is always changing, the patients are always changing, the dynamics are always changing, technology is changing, we work in an ever-changing environment, so I thought this would be quite a good topic to touch on in acute medicine. Going to talk about the human factors that lead to error in acute care, understanding cognition and cognitive errors, introduction to situational awareness, which is a personal topic of mine, concepts in patient safety, leadership and team working, and effects of fatigue. So patient safety is defined as the freedom from accidental injury due to medical care or from medical error. Anyone involved in the medical care of a patient can be involved in patient safety and should be involved in patient safety. An error is a mistake that is made. Now there are a couple of different types. So there are clinical errors which are technical. So for example, the wrong vessel is tied off in surgery, or human non-technical skills where, let's say, the surgeon tied off the wrong artery because he was tired. Remember the fundamental principle in Hippocrates, which was to abstain from harm or wronging any person. There has been historically a problem of blame culture, where it's blame the nurses, blame the porters, blame the junior, blame somebody else. I like to think that we are moving away from that into a more conducive learning environment, and so certainly one of the traits that would be good for you to develop as you approach qualification is to think about how you deal with patient safety and how you are going to be a safe junior doctor. When we look at causes of death, this is data from the United States, sliced from 2013. This is data derived from the CDC, the Centers for Disease Control. You can see that cancer-causing deaths totaled 585,000 and heart disease 611,000. But not far behind was medical error, at 251,000 causes of death in the United States. But just as a point of view, remember that this isn't even officially counted. Medical error is not recorded on US death certificates. So as I was saying, the NHS has been on a journey to learn from other industries such as aviation and nuclear energy, whose consideration of human factors has been around a lot longer than we have in the NHS. I've put up here a snapshot of the NHS Improvement website. There are a selection of videos on patient safety on YouTube, or if you search NHS Improvement on YouTube, there are some quite short introductory videos which give you more information about patient safety. So let's talk about human factors. So these are systems, behaviours or actions that modify human performance, and they can be attributed to the individual. So is the individual tired? A team of individuals? Is the team tired? Is there a communication breakdown or disagreement? Or the way these individuals interact, how people communicate and work together. And of course also how you interact with the working environment, so working in enclosed spaces, for example, working in different environments such as critical care, the ward, outpatient, so on. And these operate on two levels, which I'll go through now. So level 1 human factors are how humans work in a specified system or environment. This is otherwise known as ergonomics, and it basically looks at human capabilities. How much can we perform? What are we able to do both mechanically and mentally? There are the designs of systems to maximize safety, and the idea that's explained here is that machine and man to work together, and how can we do that efficiently? So a good example of ergonomics, as you can see here, this is a design of a chair, sitting height, so you're looking at safety in your eye line, the distance between the person's head and the screen, and how tall they are and so on. You've got a standing desk on the right hand side, so you can see how actually when you break down ergonomics into its constituent bits, it's all quite important. I'm sure we've all sat on chairs or looked at computers with the wrong glare or at the wrong height or crouched over to use a computer and look at patients' blood results. Level 2 human factors cover cognition and error, situational awareness, leadership and teamwork, personality and behaviour, communication and assertiveness, decision making, and effects on human behaviour such as tiredness and fatigue. So this slide isn't actually about Swiss cheese, but it is about a model that allegedly relates to Swiss cheese. I have to say I'm not a Swiss cheese eater myself. But it's an adverse event can be a catalogue of sequential errors which then line up with potentially disastrous consequences. And so errors in surgery are quite a good example of that, where let's say the patient has a wrong operation where the consent form was done in a prior clinic, the consent form wasn't checked on the day of surgery, patient goes into theatre, the demographics are the same, but the consent form, let's say, wasn't checked, and the procedure goes ahead and the wrong procedure is performed. So the idea of the Swiss cheese model and its system is that the more checks there are, the less chance of the failure. But this also has to be balanced by the complexity of the checks. So if you start to have increasingly complicated steps in, let's say, a patient check-in process, that could also be counterproductive, because actually at a human level, most of us just want an easy life and to have a fairly straightforward day at work. Remember that communication errors underpin a significant proportion of reported critical events. Let's have a look at the model in a bit more detail. So this is your slices of Swiss cheese. I'm told it's Swiss cheese because it has lots of holes in it. Now you've basically got hazards that run all the way through the slices to significant losses, and that could of course be the loss of a patient's life. Now each slice aims to prevent error. So this would be, let's say we're booking a patient into theatre, or when they arrive into the emergency department that you want to register them. So you want to try and prevent error at each stage. And each slice represents the defences or barriers that an organisation might have to try and prevent progression to losses. So that of course looks at the culture of the hospital. How is it that people get on? Are there behavioural issues, team working issues? Is the leadership of your department good? Is there technical support? Is the IT system easy to navigate? Has everyone been trained on the same IT system? Is there enough members of the team that are able to use this IT system, and so on and so on. And where the holes come from is just to elaborate on the fact that the levels can fail at any stage in a process, causing loss. At a more organisational level, so you have this idea of defences. So these would be organisational defences. So what systems rather has the organisation put in place to protect the patient? Our professional responsibility, so for example a GMC code of conduct, which obviously stipulates how we as medical professionals should behave and how we should conduct ourselves. Then of course there's the team ethos. How is it that, let's say, the acute medicine department is structured? How is it led? What are the team dynamics? And then of course there are the individual and technical defences. So have you done, let's say, a lumbar puncture numerous times? Have you been trained in lumbar puncture, and so on. Now then you have latent organisational failures. So this could be a policy failure. Let's say that the wrong sized needle is used in lumbar puncture, and that's because the policy doesn't state what size should be. Then you have responsibility shifting. So this might be, for example, a middle grade doctor blaming the junior doctor and shifting the responsibility. Is it that the person doing the lumbar puncture, for example, didn't have adequate training and or hadn't been signed off for the procedure? Or is it that they were just tired? And to give you an example, not that long ago I was trying to do a lumbar puncture at the end of a night shift. It'd been a very busy one, and I didn't quite get it. Now technically I was competent, but maybe actually I shouldn't have done it because I was tired, and one of my colleagues did it during the day and was much more successful. So again, these are the type of things that actually really play into giving good care for our patients. So when we think about human cognition, the first thing to remember is, of course, we're not perfect as human beings. We have a fragile cognitive function. There are lots of things, of course, that will influence our cognition, whether we're tired, time pressures, complex patients. You have to take lots of factors together and pull them together to make a diagnosis, and then communicate quite complex thoughts, ideas and opinions. When we look at autopsy data, it actually shows a diagnostic error rate of 10 to 20%, and these are from a couple of studies in 03 and 06. There are a couple of types of cognition. One is called conscious cognition, which is learning a new clinical skill, and this is something that can be slow and laborious and requires effort and using working or short-term memory. And this type of conscious thinking is used in certain types of activity, for example, when a new skill is being learnt. It often occurs in a critical situation and requires significant conscious effort. Conscious cognition is also used in overriding a routine or more mundane situation where the thought suddenly occurs, am I doing this correctly? So, for example, when we are prioritising a patient, cannulating a patient and so on, or even taking an arterial blood gas, let's say. There are a couple of different types of cognition errors. There's slip error, and this would be, for example, omitting something that you needed to do in your procedure. Inappropriate action, so doing something that you otherwise wouldn't ordinarily do. Repeating something that you may have already done. Doing something in the wrong order. Or having an error at the wrong time. So, for example, did I make an error in doing the lumbar puncture after a night shift rather than hand it over to my colleagues? Is it the wrong object, such as wrong limb surgery? Then you can have lapse cognition errors, and this is known as sort of cognitive failure in the storage of skills or knowledge. So is it that can you remember how to do a lumbar puncture? Can you remember to do a ABG and so on? When was the last time you did one? It might be an omission or delay doing something planned. So, for example, have you forgotten that you are due in acute medicine clinic? Have you forgotten that you're due in theatre? Forgetting place or person names can be a cognitive error, which worries me a little bit because that means I probably have a slightly rotting brain. But those are an example of lapse cognition errors, and forgetting what you were doing. So this is a little slide from the East Midlands Emergency Medicine Educational Media, and this just gives you quite a good overview of cognitive offload. Now, for those of us that work in acute and emergency medicine or critical care specialties, the most important thing to remember is that your brain can only process so much. So you'll often find, particularly as medical registrar, for any of you that have had the chance to spend time with us yet or will do in due course, you're often getting multiple inputs. So, for example, what's the plan of the medical patient in bed 5? Can you have a quick look at the ECG? We've got another medical referral, or there's another medical emergency team call. Can you go? And sometimes, actually, in my experience as a registrar, these things all happen together, often at the same time, for a good relentless period, plus your bleep is still going off. So you want to think about how you can offload. So you can use checklists or guidelines, so using a procedure checklist. Share the help, ask your colleagues for help. Can you delegate something to another colleague, avoiding interruptions. That would be wishful thinking, I suspect, but trying to do things in a concentrated manner. Using your team for ideas and support. So when I was last on call, we'd have sort of huddles 3 times a day to just see how the team was doing and whether we needed to make any changes. And of course, try and finish what you're doing before moving on. So I've got a little task for you. So I'd like you to watch the following YouTube video, also on Moodle, called Just a Routine Operation. Now, some of you may have seen this before, but I'd like you to write your thoughts and spend some time reflecting on it. You may wish to discuss this in Acute Medicine Forum, and of course you're very welcome to ask me about my own experiences, which we can potentially talk about either in forum or in a Blackboard session. So the video was all about Elaine Bromley, and she was a fit and well elective surgical patient who had come in for a routine ENT procedure. After induction, a situation called can't intubate, can't ventilate developed. And as a review at the coroner's court, it was clear that there was a sequential catalogue of errors, technical and human. Have a think about, having watched the video, what they might have been. Sadly, Elaine never regained consciousness and died. Her husband was an airline pilot and is now chair of the clinical human factors group. So situation awareness is the perception of elements in the environment within time and space, the comprehension of their meaning and the projection of their status in the near future. And that was a definition by Mika Ensley in 1988. You want to gather a complete picture of the environment about them relative to the task. So, for example, let's say I'm going to put in a central line for an unstable patient. Am I doing it in the right place? Do I have the right equipment? Do I have the right assistant? Do I have an ultrasound? Am I doing it in a sterile environment? Do I have the necessary drugs? And so on and so on. So you want to then put together a mental model of the status of the current task. How well is this going? Is now the right time? Should I postpone? Is this now the right time and place? You want to take in current information. So is it, for example, that I was just about to scrub up for a central line insertion when in the next door resus bed a 999 call came in and the patient was in cardiac arrest? Thinking about your own past experiences, how many times have I put in a central line, which my own experience is probably too many to remember. But you know, is the situation similar or the right one compared to when you've previously done a procedure? And then that way you can use your mental model to project plans, responses and make decisions about whether you might, for example, do a central line in theatre instead, or take the patient to ITU, or consider an alternative like a peripheral line, for example. So I'd like you to study this picture for me. So this is obviously a theatre scene. I'd like you to think about situational awareness of the 4 people pictured there. What do you think will influence their situational awareness? What are they focusing on? What are they not focusing on? What are the possible connections between the 4 of them? So just spend a few minutes having a look at this photograph and thinking about human factors. So, for example, what I've had a look here is I've just drawn some very simple diagrams about where it is that people are focusing on their own situation and the awareness of it. So let's start with the anaesthetist at the back. So he's obviously concentrating on the monitor, for example, and of course the head of the patient, and he isn't necessarily seeing what's happening surgically. Now, I've drawn a dotted line, for example, between the anaesthetist and the surgeon. Now, the relationship between those two is crucial, but actually you notice that there is a screen in between the surgeon, the scrub nurse, and the anaesthetist. So actually you have a physical barrier between the two. So it might be possible that if the anaesthetist sits down, for example, especially if say it's a long surgery, then the two actually won't be able to see each other or give each other verbal or non-verbal cues. So you'd have to make an effort to stand up if the situation changes and talk to your colleague. That's why I've put it as a dashed line. The relationship, of course, between the scrub nurse and the surgeon goes 2 ways. So The scrub nurse is going to be anticipating what it is the surgeon is doing and is planning on doing next. So she's obviously very focused on handling of instruments, the sterility of the field, and is obviously very focused on the relationship between her and the surgeon. In addition, the surgeon, of course, is focused on the scrub nurse. So the surgeon and the scrub nurse will have an intimate relationship of the surgery and what it is that needs to get done. And of course, the surgeon and the scrub nurse will need to be familiar with each other's preferences. So, for example, what sort of sutures does this particular surgeon like for this particular operation? And of course, the scrub nurse, of course, is making sure that her tray is tidy and that it's efficient, ready for any situation that might arise. She'll also have to have backup plans, for example. So what if, let's say, there's a major arterial bleed? Does she have access to the vascular emergency trays, and so on? Then on the right hand side, you've got what could be a medical student, for example, who's observing both the procedure and the anaesthetist and the scrub nurse, and all looking at the dynamics of theatre overall. So each of those 4 participants in that picture will all have quite a different perspective of their own situation and their own degree of awareness. So in an emergency team, it's important that you maintain yours and the team's awareness. Team members will often share their mental models, and there'll often be some overlap between them, such as in theatre. You want to undertake a briefing where possible, such as allocation of roles in cardiac arrest, and where possible debrief. Debriefing is a really powerful tool, and this is something that the Trust is currently doing. For example, debriefing from COVID, looking back at it all and deciding what was good, what was bad, and what the organisation should do differently. You may observe something important and relevant to another team member's task. So this is really important for those, for example, let's think about that medical student back in theatre. So she could have observed something dangerous that other people haven't noticed. Let's say there's a cable trailing around in theatre and someone might trip over it. Actually, that's relevant to the entire team, because any 4 members of that team could trip over on that wire. So it's important that if there's a problem, or otherwise known as a red flag, that you need to ensure that the other team members become aware of it. And so vigilance and monitoring of your own situational awareness at all times is really important. So for those of you that have watched the Resource Council video, at the start of that video there is a briefing, and just as a reminder, there is a resuscitation section on Moodle as well to accompany this video. So you're going to have people that all have different types of skills, experience, and different aspects of their own leadership, both personal and professional. So let's have a quick look at these 4 people here. So you've got a team leader overall. So the team leader, if you like, is the conductor of the cardiac arrest orchestra. But you've also got someone on the left who's an airway lead. So she has expertise. She will be her own leader in her own field. As you can imagine, the consultant anaesthetist runs the operating theatre. Then you've got the junior doctor, so she will have her own level of expertise. She'll be subordinate to the team leader, but again, she may well have trainees under her that she teaches. And of course, the senior nurse will have seniority, management experience, but again will be guided by the overall team leader. So all of them will only have their levels of expertise and leadership level. So in this meeting, it's good to do your introductions. You want to know who you're going to be working with. You want to do allocations, check skill mix, have all of them done an advanced life support course, for example. Are they regularly on the arrest team? Are there any injuries, for example, that means they might not be able to do something, say, like chest compressions? Then you want to check the understanding. Is everyone agreed with the plan? And you want to make sure that you've got an executable action plan. So team members must value all the information that they are offered. The most junior person in an acute team must feel free to speak up, and obviously on the acute placement, all of the students were encouraged and are encouraged to ever speak up if they see something they're concerned about. You want to think about these concepts about input, memory and cognition, that information must be gathered accurately. You want to remember that information and be able to sort it, and then you want to process to anticipate the future. Remember, situational assessment is a constant dynamic processing. It's certainly not linear. Let's have a quick look at this picture here. So this is a picture, as you can see, which looks chaotic. There are probably 4 or 5 or even more, 6 people around each patient in a confined space with monitoring and equipment, but you'll notice that I have circled the blue doctor at the end, and he's probably this is an American picture, so this is the attending physician here who is looking out across his orchestra to make sure that all of the different parts of the team are working together in harmony. And you'll notice that the attending physician isn't getting involved practically. He's not trying to do anything. He's simply overseeing the whole exercise to make sure that it's safe, and we'll talk about leadership in a minute. So when you're thinking about your role as a team leader, you imagine you want to put yourself in the middle of this Venn diagram. So you'd be thinking, well, what do I know as team leader? What do you know as team leader? What does she know as a member of the team, and what does he know as a member of the team? And this should all then be synthesized into what the team knows, and this is known as team situation awareness. Let's have a quick look at, so this is another trauma bed here, and you can see that when you're thinking about the inputs that you have into your team, and when you're standing at the end of the bed assessing someone who is poorly, you're going to have sensory inputs as well as sound and so on. So let's have a quick look at some of the sensory inputs that you're going to have here, sights and sounds. You might have input from the computer. You might need to look up blood results. There will be electronic devices. There of course will be a patient in front of you. There will be a upload of the monitor up on screen. You've got a mini monitor above the patient. You might have x-rays, imaging, ventilator, ultrasound, all to look at and try and process the difference. So if you can imagine inside a busy resuscitation room how much overload that you can have whilst trying to assess someone who's poorly. And remember, of course, that sight is fallible and images can be misread, giving a rise to errors in processing and interpretation, and therefore your clinical decision making. So personal awareness traps are things like feeling of being ahead or behind a situation, which will promote anxiety. Becoming preoccupied. Is it that you have something else to do? Do you have another sick patient to go to? Have you got a very high workload? Are you distracted? Have you had a problem at home and you're distracted by it? Is there a lack of or incomplete communication? Carrying out an improper or inappropriate procedure, a lack of experience, adverse environmental conditions, and fatigue. Team awareness traps, if we have another look at this picture, are ambiguity. So is there ambiguity in what it is that the team is doing? Is there a fixation on something, like putting in a chest drain but ignoring the fact that the patient has an increasingly distended abdomen? Have we put a cannula in? Is the patient on oxygen? Is the attending physician there, and are they leading the team? What are we missing? Is it that we are missing to improve the patient's blood pressure or HB in anemia? Is everyone in appropriate PPE? Conflict, is there a battle between the specialties? So is it that a vascular surgeon wants to take them for an emergency operation, but so does the orthopedic surgeon? What if the intensivist or anaesthetist wants to delay until the following morning? Is there a communication failure, both verbal and written? So in emergencies, staff come together who often infrequently or never work together, and you have to function effectively in a stressful, potentially complex, time-limited situation. When you're being a leader, you want to have appropriate use of authority, communication, and situational awareness. As I was saying earlier, for example, in the resource huddle meeting, there are often multiple leaders, such as anaesthetist, medical registrar, and senior nurse, or medical, surgical, and nursing. And it's important to realise that when we think about teamwork leadership, that expertise is not necessarily the same as seniority. So what are the attributes of good leadership? So you want to think about directing and coordinating your team, encouraging the team to work together, motivating and supporting the team, and that can be through practical advice or doing a skill that you are particularly accustomed at doing. It can be emotional support if you've had a difficult resource case and the team needs to debrief. It might be that you just give some advice over the phone. You want to plan and organise with an emphasis, of course, on safety. The buck stops with you, as the mantra goes. You want to develop team knowledge and skills and attributes. And finally, you want to be able to assess the performance of the team and assigning tasks. And you want to be able to allocate those to known skill levels. So it might be that you ask the FI1 in a cardiac arrest to put a cannula in. You might ask the airway doctor to put in an airway, and so on. So leadership. So what makes a good leader? So you want to model the behaviours and values of the team in which you are supervising. You want to have technical proficiency. You want to be knowledgeable, approachable, dynamic and decisive, self-motivated, organised and able to complete tasks, good at time management and able to delegate appropriately. So these are some of the four key frameworks in good teamwork. That's supporting each other. And again, that can be physically, emotionally, and in terms of knowledge. Solving conflicts, exchanging information. So, for example, a nurse might measure the blood pressure and then exchanges that information with the doctor and the team leader. And then coordinating activities. So, for example, asking the FI1 to ring the radiology registrar on call to prepare and book a CTPA that the registrar feels is appropriate because the registrar has exchanged information with the nurse who have told the patient, told the doctor that the patient, let's say, is hypoxic. So the four key aspects of decision making are assessing the situation and defining the problem, generating and considering one or more options, selecting and implementing an option, and reviewing the outcome. So this is the Yerkes-Dodson law. So task performance, including decision making, is not optimal when we have low levels of arousal or stress. Performance improves with more stress, but above a threshold of increasing stress, our performance deteriorates, and this is known as the Yerkes-Dodson law curve. This deterioration in performance impairs our ability to make good decisions under significant stress. So, for example, this was devised by my colleagues up in Lancashire. It's a decision aid in emergencies. So, for example, it's STAR, which stands for Stop, Think, Access, Respond and Review. So, stop, is the procedure need to be carried on? Think, is this the appropriate procedure? Access, can this be done in any other way? Respond, I will, for example, alter my action plan or technique. And review, has this made it less hazardous to do the procedure? So you want to think about things like situational awareness to recognise and define the problem, generation or consideration of one or more options, selection, implementation and review. So, for example, in British Airways, they are taught TDODAR, so time available, diagnosis, options and associated risk, decide upon action, assign tasks and review. So let's just go back to our picture of our sleeping colleagues and think about fatigue for a couple of last slides. So what sort of effects does fatigue have? Well, it can adversely affect your thinking, can reduce your ability to cope with unforeseen rapid changes, reduced ability to adjust your plans, more rigid thinking, less effective coordination, poor timing, poorer communication, social withdrawal, less tolerant as a person, irritability and distracted by comfort. And this is work by Flynn et al. In 2008. Another way of thinking about your own situational awareness and level of fatigue is I'm safe. So you might want to ask yourself these questions. So illness, could my illness affect my performance at work? Medication, am I taking any medications that might affect my performance at work? Stress, am I stressed? Is it sufficient to draw me away from my focus at work? Alcohol, have the effects of last night worn off? Fatigue, have I had enough sleep recently? And eating, have I eaten appropriately to prepare me for a working day? Which I'm afraid is not a problem that I have, sadly. And just remember that patient complaints or issues should always be taken seriously. This is just a screenshot of the PALS service, so Patient Advice and Liaison Services. PALS is a common acronym used across all trusts as it sets the standards for how people should raise complaints and how they can be dealt with. Obviously, it's better if you can deal with a complaint directly with your patient, of course, using the duty of candour, being honest and explaining and trying to improve the system. Okay, everybody, thank you very much for listening. Feel free, of course, to start a discussion on anything that we've talked about today, or post any questions, and I'll speak to you soon. Take care. Bye bye.